Hello, good evening, everyone. Welcome back to my IVF Answers and the European Fertility Society. I hope you can hear me loud and clear, and we are back to discuss ovarian stimulation protocols today. And as you can see, we already have our special guest, Dr. Kristýna Frühaufová, is with us today from GYNEM. She's the head physician at GYNEM Fertility Clinic in Prague. So we are happy to have you back and hope you had, I'm sure, busy, but a good day and are ready to educate us on various protocols in IVF. And of course, we will start with your presentation. How are you? Good to have you here.
I'm fine, thank you. Good to be back again.
Definitely, it's lovely to have you. Thank you so much for joining. I thank you for confirming that you can hear me as well. And of course, remember that it's recorded and you will have a chance to ask your questions. And remember, you can just put those in the chat during the presentation or afterwards. And there will be around 30 minutes for your questions. So don't hesitate. It's all anonymous, and Dr. Kristýna is definitely here to help you out with any questions you might have, anything that's on your mind. And this topic is, I think it's not always easy. And there are many different medications, there are many different protocols, and I'm sure this is something that that's why you are here, of course, to learn a bit about it. And don't hesitate, we are definitely here to support you. My name is Caroline. I'm glad to be here and be able to discuss this topic with Dr. Kristýna. And I think we can go ahead with our presentation first. And as I mentioned, remember, all the questions will be answered right after Dr. Kristýna's presentation. So don't hesitate. And now I think we can go ahead with the presentation, right?
Okay, thanks a lot for the introduction. So my role today is to navigate you through, try to make you understand how the ovarian stimulation works and what are the different protocols, what are they used for. So no matter if you have already started your IVF journey or if you're new to the IVF, I hope that this webinar will be helpful for you. So basically, the ovarian stimulation means administering hormonal medication to make more follicles grow inside the ovaries and to increase the chances to obtain multiple eggs within one hormonal cycle, one ovarian cycle. For that, we use in Czech Republic mostly the ultrasound monitoring during the stimulation. In some clinics, they prefer to check the hormonal levels or use both of those options at the same time. The average length of the average ovarian stimulation is about 11 to 14 days. So what kind of medication we use to stimulate the growth of more follicles on the ovaries? In most cases, we use so-called gonadotropins, which may be recombinant or urinary. Those two differ from the way that they are manufactured. The recombinant, which in most cases is the pure FSH or FSH and LH, are manufactured completely in the laboratory conditions. The urinary products are derived from the postmenopausal urines. And those types of medications are used in the form of injections. We also use so-called anti-estrogens, which are the hormones that will help us with the stimulation as well. And these are used in the form of tablets. Then there are some other medications, such as the GnRH and agonist or antagonist, that are used to prevent premature ovulation. And to finalize and to time the ovarian pickup, we use so-called trigger shot. In most of the cases, either ACG or GnRH agonist differs from different types of protocols. So how do we select the type of the ovarian stimulation protocol? It's based on many factors. For example, DH, the ovarian reserve, that can be measured by AMH or something that's called antrofollicle count, which is the number of small follicles seen on the ultrasound. Also, by all means, the ultrasound image of the ovaries. Then we can use or measure the hormonal profile. And also we take into account if there's been any previous cycles in the past, what was the response of the ovary to the stimulation. Another important factor is the body weight or the BMI, especially the percentage of the body fat, because the higher the percentage of the fat, the higher the dose of the medication we have to use. You can imagine that the fat tissue sort of dissolves the medication, so we actually need higher doses. We are always trying to fit the protocol to that particular patient, so there's no one fits all kind of protocol. So in most of our patients nowadays, the golden standard is so-called short antagonist protocol, which is suited for like the average patients or the patients also with the high risk of OHSS. The ovarian stimulation itself starts on the second day of the cycle. Then GnRH antagonist is added either in like most of the patients around day 7 of the cycle or based on the ultrasound finding. The role of the antagonist is to prevent the premature ovulation. Then the final oocyte maturation is triggered either by the ACG or GnRH agonist, depending on the number of the leaving follicles. So generally, when you have more than 20 follicles, we use the GnRH agonist in prevention of the ovarian hyperstimulation. This protocol has some pros, which is like the shorter duration, lower risk of the ovarian hyperstimulation. Also, it's quite flexible, so we can adjust the dose throughout the stimulation. And there are some disadvantages, but those are not like major. So we have to monitor throughout the stimulation, but we have to do that in any type of the stimulation protocols. And there might be a lower yield of the mature oocytes in some patients. The other option in the normal responders is so-called long protocol. This consists of the downregulation with GnRH agonists that actually starts prior the menstrual bleeding, so in mid-luteal phase, around day 20 to 22 of the previous cycle. Then we have to monitor the ovaries in about 2 weeks. And with that, we start the ovarian stimulation with gonadotropins. Then basically the base of the stimulation protocol is the same as in the previous stimulation protocols. This type of protocols usually brings the higher percentage of mature eggs, so it allows better follicular growth, better follicular synchronization. So it's especially used in patients who had previous antagonist protocols with let's say dysynchronized follicular growth. The disadvantages are, of course, it takes longer, the whole thing, about a month, and there's a risk of ovarian hyperstimulations. And also, this kind of protocol is not suitable for patients with low ovarian reserve. For patients with lower ovarian reserve, we have a so-called flare-up protocol, which starts again on the second day of the cycle. In the beginning, using the GnRH agonist that will make the body produce FSH and LH. This is the flare-up itself. And with that, we add the gonadotropins to the stimulation. This, especially, as I mentioned, is used in patients with lower ovarian reserve. There is a bit higher risk of premature ovulation. So again, we have to be very cautious about the ultrasound monitoring in this case. When I'm speaking about the poor responders, there are different protocols that may be used. To some patients, soft stimulation, which consists of lower doses of gonadotropins in combination with, for example, antiestrogens, might be the best choice because it will produce the highest number of follicles, cutting down the cost of the medication and the possible side effect of the stimulation. In some patients, we use something that's called dual stim. This is specially suited for patients who want to, let's say, accumulate more embryos within a short period of time. The dual stimulation means that you have one stimulation starting from day 2 of the cycle, followed by the oocyte retrieval. And then in the luteal phase of the cycle, there is another consecutive stimulation that usually leads to the yield of more eggs within one menstrual cycle. In those types of protocols, there may not be fresh embryo transfer. These are only suited for freezing the embryos. Then there is another option that's called the letrozole protocol, which is the combination of letrozole with gonadotropin throughout the whole stimulation. This kind of protocol I especially used in oncologic patients who are at high risk of having like hormonally sensitive cancers to control the levels of the estradiol. For patients with PCOS and patients with high risk of ovarian hyperstimulation, in most cases, we use the GnRH antagonist protocol. We use usually the lower doses of gonadotropins, or we use so-called step-up stimulation, which starts on lower doses of medication and gradually over the stimulation, it goes higher based on the ultrasound finding. In the patients with the risk of overstimulation syndrome, we use the GnRH agonist trigger instead of the ACG. Then, of course, comes the freeze-all strategy, because after the GnRH agonist trigger, the endometrium is not fit enough to sustain good conditions for the embryo transfer. So, as I mentioned, the freeze-all strategy applies to patients with a high risk of OHSS. It's like the most powerful preventive tool for the ovarian hyperstimulation, or in patients where we test the embryos genetically, no matter what method we choose, be it a PGTA, MRSR method. So in those types of patients, we only do the oocyte retrieval, then sort of create the embryos in the lab and wait for the outcomes of the genetic testing. So in conclusion, there are several factors that we take into consideration when selecting the best approach to the ovarian stimulation. The most important is the ovarian capacity, the age of the patients, if there's been any previous cycles in the past, so we take this into account, and what was the outcome of the previous cycles. There is no golden bullet, so there is no one-fits-all protocol. We have to really individualize the stimulation protocols. And we have to keep in mind that the response to the same protocol in the same patient might actually be different in different menstrual cycle, because in each menstrual cycle we do produce different levels of FSH, or we have different antral follicle count in each cycle. So there might be differences. And also, if you do have consecutive stimulations that are happening within like a short period of time, the receptors on the ovaries may actually wear out, and the ovaries become less responsive to the hormonal stimulation. So basically, if you want to do like several stimulation cycles, you can do the back-to-back, which means one cycle and then the consecutive. But after that, we advise to take at least 3 months break from the stimulation, because if you do too many consecutive cycles, the response of the ovaries might be not adequate. So thank you for your attention. I hope that I got you some brief introduction, and I'll be happy to answer your questions.
Now I will go to the longer. There are 3 questions in one. Let me show you this,
Mhm.
okay, from Catherine. Is there any different protocols for different waves of equipment? Should different brands of medication impact differently? Pergoveris, right? And as you can see, my MH, sorry, there's actually, I think, follow-up, 0.8, 844, good response to the medication, now running out of money for IVF. What is your suggestion doing IVF medication injection to produce a few more eggs to ovulate? What protocol? Anything you can advise here?
Yes, if we are speaking about, for example, dosing, which is like different stimulation in different phases of the cycle. So I think that would apply to the first question, first part of the question. We know that in the luteal phase of the cycle, you need high doses of the medication because when you have the corpus luteum present, then you have to top up the levels. Sometimes we combine the let's say the soft stimulation with the gonadotropin stimulation for that. If different brands of medication should impact, should have like different outcome of the stimulation itself, there are several studies to that because, for example, the Mariofert is a bit different from Pergoveris because Pergoveris is completely man-made medication consisting of FSH and LH hormone, the ratio being 2:1, FS2 to FSH to 1 LH. In Mariofert, you do have the FSH, it's a urinary product, with the ACG, that the ACG itself acts on the receptors as an LH, but it does bind differently. So what the studies say is that in the terms of the number of the follicles growing on the ovaries, you have the same response, but you do have lower pregnancy rates in patients using the urinary products, which might refer to, let's say, lower egg quality in the end of the stimulation. So you seem to have similar numbers of the eggs, but the egg quality might be different, and that might be due to the ACG binding differently to the receptors than the LH itself. So the third part is quite tricky because what really stands out is the age, unfortunately. At this age, it's not only about the MH, it's not only about the ovarian reserve, but the age itself. So we know that it takes about 8 to 9 blastocysts to have a euploid one, which means around 25-30 eggs obtained by the stimulation. So there's usually several cycles needed to obtain a single good quality blastocyst.
Okay, thank you. And I will ask you actually, because sometimes it's important to ask. So can you tell us what was the oldest patient you had who was able to succeed, right? Because from the different clinics,
You
of course,
just yes, we just looked at the statistics from the last year, and there are different measures that the IVF clinics, of course, how to sort of sum up our work and how to sum up the quality. And you also have to read those numbers properly to get the right answer. So usually what the clinics sort of let's say introduce what numbers is the pregnancy rate, which means what proportion of patients undergoing the IVF will get pregnant. This might be the biochemical pregnancies or the clinical pregnancy rates, which are like viable pregnancies with detectable heart rate. And there is something that's called take-home baby rates, which is the final number that you would like to see as high as possible, which is the number of the healthy newborns. So when you look at different age categories, generally in women up to the age of 35, you're about to have like 40% success rate, which means that 40% of the patients will have positive pregnancy tests with quite low rate of abortion rate, which is the percentage of women having miscarriage in the end. So you do have high ratio of patients actually giving birth in the end. This is completely reversed in the age 42 and more. So I can tell you that last year we did have one single live birth in the category 44 plus.
Okay.
So we actually got up to, let's say, 8% pregnancy rate, but the abortion rate was really high. So we did have one patients
That's why I
making it
asked.
all the way.
So just to, just this is not easy, right? So this is why I
Yes.
ask this. This is something that you can think about it. That definitely only one person in 1 year in this case. Yeah. Okay. Thank you for the clarification. And now again show you a question from Ellen. 38 AMH is 0.9, and I responded better on letrozole only, but when I started on short antagonist protocol from AFC 13, got only 6 follicles, 3 were empty, got only 3x and 2 matured. What is the possible cause of empty follicles? What would you suggest that can increase that count? Would you advise Omnitrope to improve quality of eggs?
Well, usually the proportion of the mature eggs doesn't equal the number of the follicles that we actually see during the stimulation. This would need more insight to see if the 6 follicles were at the same size, for example. If they did differ in the size, then I would still go for a long protocol in this patient to try to get the follicles starting to grow at the same time. The MH 0.9 is not that low, and if you do have good antifollicle count, that still might give you a chance to grow a decent number of the follicles. If you decide to stick with the antagonist protocol, I think that, yes, short antagonist protocol, then sometimes we use the combination of the trigger shot, the GnRH, and the ACG that might actually help to gain more eggs within one cycle. And the Omnitrope is still considered to be, let's say, off-label medication for the IVF. So we are actually not allowed to use it in Czech Republic.
All right, thank you for yet another question. I do hope it helped. Let us know if there's anything of course else you wish to ask. You know what to do. More questions are in. Gabriela would like to know age 43, AMA 0.5, 4-5 foci. What protocol, excuse me, for stimulation is better, right? For better quality. Sorry.
Well, I think that this is like the perfect patient for the soft stimulation in my eyes.
Yeah, soft stimulation. It is.
Yeah,
thank you.
the mini IVF.
Okay, and now I will again show you a question. This one in the long protocol, when you talk about downregulation of GnRH agonist in the luteal phase of the previous cycle, do you mean the anti-baby pill? If yes, is it important to keep these 2 weeks in the center where I'm going now, IVF, doing now IVF? I was asked to take anti-baby pill for 1 month duration of my cycle, and then I will have to start the IVF cycle following the long protocol.
It's not the same thing. In the long protocol, actually using the GnRH agonists, either in the form of a nasal spray or injections. To be honest, the long-term injections do work the best. So it's basically the one injection being introduced on day 20 to 22, then its action lasts for 4 consecutive weeks. So you have enough time to see the effect of the downregulation on the ovaries. and then to start the stimulation. So you don't actually need to add any other preventive measures to prevent the premature ovulation during the stimulation. So you basically just add the gonadotropins later on. The anti-baby pills are used in some centers, especially as a form of the timing of the IVF cycles, because some centers do have a waiting list, for example, and it's more difficult for them to squeeze the patients in randomly when they start their cycles. Or as we spoke before about the estrogen priming, so the baby, the contraception basically works the same.
Okay. I hope that helped. More questions are right here, so thanks a lot for those. And let me have a look. Okay, next question is from Catherine. I just need to go back. I just saw it. Okay, yes, it's here. Sorry. Is it better to switch around with the medication to keep up with good response if we do back-to-back stimulation? I'm afraid to switch the medication. Should I give 2-3 months or break between?
Well, as I mentioned, you can do back to back within 2 cycles. That's okay.
Okay.
Again, depending on how much time you have. So that's, I mean, if you have to take the age factor into consideration as well, then it's better to do back to back than wait 2 to 3 months. If you are like if you're speaking of a woman less than 35 years, then I would suggest to give it a break in between the cycles. So there are those factors that you have to take into consideration as well. But generally, doing 2 consecutive simulations after one after another shouldn't actually result in a lower number of the eggs yield.
Okay, thank you. I don't see the age here from Catherine. She has some. She do has. Sorry, she has some questions. More questions, I mean. So what is your views on supplement during the stimulation? Which one you suggest? What do you think about the HEA before or during stimulation? And one more, other lifestyle should be cautious during the stimulations.
There's no hard data on the actual use of any supplements having any benefits of the IVF stimulation itself. The DHEA itself does differ because you have different manufacturers, you have different doses, and it's a supplement. It's not a medication, so you really don't have any like hard recommendations what dose to use, when to use it, how long to use it for. And as I said, there are no clinical studies actually proving that it will help to improve the results. In the terms of the lifestyle changes, there are no dietary restrictions that you should take during the stimulation. You can imagine that the egg quality is being influenced by your whole lifestyle so far. So if you did accumulate any DNA changes to the eggs, it's been done some time ago. We have to, let's say, pay the price for our lifestyles in our 20s, for example. So unfortunately, there's no magic drug that would reverse those changes if there's been any.
True. All right. Nothing we can do about that, I'm afraid, right?
Yes,
Still
unfortunately,
nothing.
yes. Male have the advantage that they actually may influence the semen quality, but you're not the lucky ones.
Sure. Thank you so much. And one more question from Catherine. I will go through to this one straight away. So I'm in luteal phase stimulation. I was on 150 Gonal-F and 150 Meriford. I got 10x, have 3 follicles left to do the luteal phase. My protocol is switched to 225 Meriford. What do you think my luteal phase sim progress? What do you think about this?
Well, I don't really. So if I understand it correctly, that the 150 gonal and the Merifert was the first part of the stimulation, and now it's like adjusting, right? So in
Yes.
luteal phase, you're using 225 millifarad. Well, I would honestly go for at least the same dose using the millifarad, for example, only, or the combination. I don't know why was this chosen, whether there was like the economical matter, or there are some limits on what medication to use for stimulation, because it does apply to some countries. So as I said, generally in the luteal phase, we need high doses of the medication to get at least the same response. Me personally, I would go for 300 units of Mariofregonal, any combination of that at least. But hope it works well.
Of course. Sorry, Catherine added, my doctor said it is due to less follicles.
Sorry,
my doctor said,
yes,
this is the only information I got here.
Yeah, well, I think that they are calculating with that there are some follicles that are left behind, and they're trying to get the response of that. Yes, I would still I would trust your doctor, trust the process.
Yes. Yeah. Thank you so much. If there's anything else, you can go ahead, and let me just go back to our previous questions. I just wanted to keep it, let's say, together. Those were questions from Catherine. Now we will go for Karen's question here. 40 in a few months, sorry, 6.1 picomole AMH, right? 4 rounds of ICSI, first 10 follicles, 2 of which best grades 4 years ago. Since follicles been 6, 7, poor quality. My BMI 30, 31, try long on first cycle, short on last 2, high doses 450 and lower on last of 300 units. Do I try long protocol flare, estrogen priming, higher or lower dose, need to get follicles together too, which I struggle with. Yeah, this is the information.
Yeah, well, the BMI is a bit of an issue here, because as I said, the higher the weight, the higher the dose of the medication that we have to use. You already tried high doses. I understand that it ended up with the same result. So again, I might suggest the soft, the mini IVF in those cases.
Okay. Yeah. Karen, if there's anything else, you know what to do. Helen would like to know, how do you balance a quantity versus quality in patients with high antral follicle count but low AMH?
Yes, this is something that is usually difficult to handle, because the AMH gives you some, let's say, the idea how the ovary is going to respond, but on the other hand, the other parameter that is used to suggest the dose of the medication is giving you some other other information. So in the first place, I would test the AMH again just to see if there is any lab error, because we know that the AMH is quite unstable parameter, and sometimes it's dependent even on the day of a time, or even at the phase of the cycle that is being measured. So just to get the idea whether there wasn't any mistake in the first analysis, because when you do have this discrepancy between the ultrasound finding and the AMH, it's always better to double check. Usually in those kind of patients, we would go for the high doses to start with. And I would go for the antagonist protocol in my, like, the first choice of protocol for those patients.
Okay, thank you. One more thing from Helen here. How do you increase number of mature eggs? I've tried double trigger with 10,000 Zizafert and 1 point Buserelin.
Yes, this is quite a big topic on any of the IVF conferences that we have. Actually, we see that the proportion of the mature eggs versus the number of the follicles does seem to be affected by the age. So in older women, unfortunately, we see fewer eggs, few mature eggs yield within the IVF stimulation. And generally, if you do have a lower number of the eggs than expected, then what you had, the double trigger or dual trigger, is suggested. In some patients, the answer might be in the choice of a different protocol. So, if possible, I've seen my patients like with the antagonist protocol ending with fewer all sides yield, and then switching to long protocol having a better yield of the eggs. So, again, different factors such as the age, response, AMH, and then if you're suitable, go for going for a long protocol.
Mm. All right. Thank you so much. Again, short question. Is the PPOS, I'm not sure here, but I think you
Progesterone
know,
prime, yes.
protocol indicated in PCOS patients?
Well, I personally don't use the progesterone primed stimulation
Mhm.
protocols, but it might be used in PCOS patients, especially in those when you're sort of expecting to freeze all, to do the freeze all strategy, then yes, you can go for that. Because again, there's some saving on the medication costs. So it's one of the options.
Okay. Thank you so much. And Karen, from our previous question, yeah. So what? Because you mentioned that it's best if she goes for soft protocol. Can you
Mhm.
just clarify? Soft mini IVF is the same as short?
It's in the terms of the setting of the protocol, it is a form of short antagonist protocol, but what we refer by using the mini or the soft protocol is usually the combination of antiestrogens with low dose of gonadotropins. So it actually means lower doses of softer stimulation with using
Yeah.
the gonadotropins.
Mm-hmm. All right. Thank you so much once again. Let me again. There's a follow up from Ellen, but before I show you the follow up, I just want you to see which question it was because there was some information. Yeah, 38, Ellen. This is the question 0.9
0.9,
AMH,
yeah.
and her follow up is right here. Just give me a second. Yeah, here it is. So my two embryos PGTA tested. One was euploid, one aneuploid. Pergoveris 300 units was prescribed, right? And
Yes.
centrotide
That's right,
250,
yes.
triggered by Ovitral 250 in Brussels. I consulted a different fertility specialist who told my dose was high based on AMA 0.9. What do you think?
Well, I think that having two embryos, one euploid, one aneuploid, is a good result. So most likely, I would say let's go for the same type of stimulation that you had, because it's not only about it's also about the quality of the eggs, which, like, having half euploid embryo is actually a good result. So I wouldn't necessarily say that 300 units of Egorace is high dose. Yeah,
Mhm.
I would agree with that.
Okay, thank you. I do hope that
Yeah.
helped. Thanks a lot for that. And sorry, I will go back. I think I missed Helen's question here. Sorry, here it is. What protocol would you recommend for 40-year-old with endometriosis? I think AFC 8, AMH 5 picomoles. I have a problem with egg maturity, leading to less fertilized eggs.
Well, again, there are different aspects. So I don't know what you mean by the problem of egg maturity. So with the anti-follicle count of 8, realistically, we can expect to have, in the best case scenario, I think having 5 or 6 mature eggs out of the stimulation is like the best response that we can expect from this kind of patient. Of course, for the patient with endometriosis, the long protocol might be suited, or something is called ultra long. But again, you have to, let's say, lower androgen follicle count, so you may not respond too well. So I would focus on getting as good response as possible. So personally, I would opt for the antagonist protocol using around 300 units of FSH or Peglovaris, for example, and then trying, for example, the double trigger for the oocyte maturation in the end.
Okay. And what protocol for
Yeah.
poor responders aged over 40?
I think that we've discussed this quite thoroughly. So the first choice would be the soft or in the mini IVF.
Thank you, just shortly for answering that. And you're right, we did mention that before. And remember, it's recorded. Of course, you will be able to check it. We will be slowly finishing. There are some questions here. There is a very long question, but basically it focuses on AI. I will show it to you. We don't need to go through all of them because they are kind of related to that. Anything you can tell us, because as you can see, its IVF protocols became increasingly personalized. Do you see a role for AI in helping clinicians choose? I think it's definitely a new topic. Anything you can advise on that? Anything that nowadays is said about this?
I don't think we're there yet. The AI is emerging in all the medical fields, and I think it's quite a helpful tool. But for example, to use, there are different ways how to calculate the proper dose. There are apps that have been developed for that. If you know the medication Recoval, you can actually use a dose calculator based on the body weight, the AMH, and it should give you the appropriate dose. But when this medication was introduced to the market, it was introduced with the hope that this will prevent the OHSS in the PCOS patients. It turned out that it's not working that well as we thought. So in my own experience, I'm not using the app
exactly. That's why I
anymore.
wanted to.
I do have it in my mobile, but I haven't used it for quite a long time now, to be honest. So I just do the dosing by myself. And as I said, there are different aspects of the patient that you have to take into consideration. For example, if you speak about the BMI, then if you have a woman who is more muscles built, she'll have a different way how she's going to metabolize the medication compared to a patient with a high density fat. So you actually have to take this into consideration as well. So if you do have two patients with the same BMI, they will look differently. So that's another aspect that the AI is not able to, let's say, take into account yet. So yeah, as I said,
we're not there
fully.
Yeah. Yes.
Okay,
but there's a chance that, of course, it as always, it's still, let's say, in the process, right? So I think we just need to watch out for it, but not yet, at least. Hey, thank you so much for answering this question as well. Definitely interesting as well. And what do you think about oral contraceptives for scheduling IVF? Do you find them harmful for IVF?
Generally not. We notice that if you're a long-term user of the oral contraceptives, and it means that you're using the contraception for more than 6 months, then the MH actually drops, and also the androgen follicle count drops, and you get a lower response to the IVF. But if you're using it for a period of 1 month in order to, let's say, do the timing of the IVF, it shouldn't have any negative impact.
Okay, and I think that now we will go for our final question for today. Here it is for letrozole protocol. What is the highest dose you can recommend?
Well, generally, when I use letrozole protocol, I go for twice a day to 2.5 milligrams, which means 5 milligrams in total per day, which is like the general recommendation what to be or should be used
Okay,
as a top dose.
brilliant. Thank you so much. I think that we've answered all
Yeah.
of your questions. Thanks a lot, everyone, for your active participation and for your questions. I do hope that it was helpful. I do believe so. Dr. Kristýna, thank you so much for again helping us out with all the questions, for your presentation, and of course explaining all aspects about ovarian stimulation. I know that we could talk more and more about this. It's always, it's never, enough. That's the truth. There are many different aspects that I'm sure you would like to still know. But remember that we will be back with some more events, and actually, Dr. Kristýna will be back with yet another topic. Next time we will talk about endometriosis. 17th of April, Dr. Kristýna will be back with another topic. So I hope we will be able to see you here as well. And of course, thanks a lot, Dr. Kristýna. Anything else you wish to add before we finish for today?
Well, thanks a lot. There's been lots of people attending this event, so I'm glad that I hope that I helped you at least a bit to understand what's going on, what's hidden behind what is, we don't actually have any secrets, but there are lots of things to take into consideration
Definitely.
when choosing the optimal IVF protocol, and even with the best expertise, the first cycle is always to see how the patient responds.
Yeah.
So, uh, fortunately, the majority of patients is lucky enough to conceive within the first cycle, but there are some percentage of patients who need some more thorough follow up and work later on to find the right approach for them, because
Okay.
sometimes what you see on the paper doesn't respond to what you actually see in the
Mhm.
reality.
Exactly. This is important to also mention that. Thank you so much indeed for this. So thanks a lot, everyone, for your questions, for your thank yous. Of course, I see your comments in the chat. Thanks a lot for that. And remember, it's been recorded and you will have a chance to watch this. It will be published on our YouTube channel and to my IVF's website as well. And well, thank you so much. Right after we finish, you will be redirected to our survey. So I definitely encourage you to take part in the survey and just simply let us know what you think, what kind of topics you wish for us to discuss, and so on. Thanks a lot. We will be back, as I've mentioned. So have a lovely evening and talk to you soon, Dr. Kristýna, as well. Thank you so much. Take care, everyone.
Thanks a
Bye
lot.
bye.